मेरी स्क्रीन नहीं होनी शुरू हुई।
सर आपकी स्क्रीन आ गई थी, अब दोबारा चली गई है।
मैं बंद करके दोबारा से करता हूँ, स्टॉप प्रेजेंटिंग करके मैं फिर प्रेजेंट कर रहा हूँ।
सर आपकी जो स्क्रीन मिनिमाइज है ना, उसको आप क्लिक करेंगे ना तो शो हो जाएगी प्रेजेंटेशन।
कहाँ पे?
सर नीचे टास्क बार पे ना राइट कॉर्नर पे सेकंड आइकन नजर आ रहा है,
ये नहीं,
नीचे बॉटम में सर, राइट कॉर्नर पे सर सेकंड
ये तो
नीचे, सर नीचे इससे
चैट
भी।
है।
नहीं, आपने प्रेजेंट स्टार्ट कर दी।
हाँ प्रेजेंट
वैसे
किया
पावर पॉइंट की स्लाइड्स ओपन
मैंने,
कर दी।
पावर पॉइंट।
जी सर
नहीं
आ
यहाँ
गई।
पे कर देना।
जी
अच्छा
सर।
उसमें नहीं जाना, राइट, ओके, राइट, ठीक है। ऑलराइट, last Wednesday, we had a presentation about hypertensive disorders in pregnancy, and then I went through almost half of my presentation on preeclampsia, but then I thought that I will present it again, and then I can present that in about 20 minutes, and later on, then we can have some discussion, question, answers. I can ask a few questions, and similarly, you can make comments or ask questions. Now, just to recap that why I say preeclampsia and not hypertensive disorders is that preeclampsia is the preeminent hypertensive disorder related with pregnancy, and the contribution by essential hypertension or the other varieties like gestational hypertension, they are comparatively few. But anyway, this is the various types of hypertensive disorders which may be associated with pregnancy, uh, like gestational hypertension, chronic and preeclampsia, and superimposed preeclampsia. We will come to the definitions of these just now. Now, gestational hypertension is something which is comparatively a newer thing. It means that this is the development of blood pressure, the definition of which, of course, is blood pressure of 140 by 90 millimeters of mercury or more. But this shows for the first time during pregnancy, especially particularly during the second half of pregnancy. And secondly, it is the blood pressure which returns back to normal within 3 months or 12 weeks or postpartum after delivery. And also, the differentiating feature is that this raised blood pressure is not attendant with proteinuria. That is how it differentiates itself from preeclampsia. So, if it is raised blood pressure plus proteinuria, it is preeclampsia, and if it is only raised blood pressure and no proteinuria, then we'll call that gestational hypertension. The timing of its appearance and more or less its effects and the timing of its returning back to normal are the same for preeclampsia and gestational hypertension. The only difference is presence or absence of protein in the urine. Chronic hypertension, if it's known previously before pregnancy, or it is diagnosed during the first 20 weeks of pregnancy, and thirdly, if it persists 12 weeks after the delivery, then it would be known as chronic or essential hypertension. There is one exception, of course, that in case of trophoblastic disease, the blood pressure can be raised during the first half of pregnancy, and then it would not necessarily be chronic hypertension. And preeclampsia, blood pressure, the same for all types, but proteinuria, it is 300 milligram or 0.3 gram protein in 24-hour urine specimen. We sometimes do it, but Generally, we rely on dipstick method, which is a qualitative assessment of proteinuria, and 1 plus generally denotes about 30 milligrams per liter of protein, but that is considered to be or not very reliable. But if it is persistently present, qualitative proteinuria, then we'll take that into consideration. And eclampsia is development of convulsions which cannot be attributed to some other cause, and in a woman who has had symptoms and signs of preeclampsia. Superimposed preeclampsia is if there is chronic hypertension and there is development of proteinuria, which is a new onset proteinuria. That is known as superimposed preeclampsia. The woman is already hypertensive, but she develops features of preeclampsia, then that would be. And some of the other features are sudden increase in proteinuria or blood pressure, platelet count of less than 100,000 per cubic millimeter uh, before 20 weeks of pregnancy. Now, proteinuria, as I had already referred to, is defined as presence of at least 300 milligrams of protein in a 24-hour specimen, or then protein and creatinine ratio. Protein in milligrams per deciliter and creatinine again milligram ratio, which is greater than or equal to 0.3, or dipstick 1 plus if a quantitative measurement is unavailable, and then it should be done serially to confirm that it really is present. And usually, like blood pressure, it is carried out also at an interval of 6 hours minimum. And as part of this slide shows that 1 plus denotes 30 milligram per deciliter uh, of proteins. HELLP syndrome, hemolysis, elevated liver enzyme, low platelet, and this is usually present, is diagnosed sometimes in pregnancy, usually associated with preeclampsia, but it can be present without hypertension and without even proteinuria, and it uh, generally denotes a severity of preeclampsia, that if it is there, then that means the preeclampsia has had severe kind of effects. And this is a situation which is associated with the high maternal and perinatal morbidity and mortality. It is important always to remember and to then, uh, to know a little bit of pathophysiology, because that forms the basis of management of a disease process. Until and unless we understand why it is there and what is the mechanism, then we'll be giving empirical treatment just like a Hakim, not really knowing why we are giving that particular, why we are requesting a certain test, and what is the significance of the test, and what is the significance of that monitoring or that active treatment in terms of, or therapeutic treatment. So therefore, it is important that we should have some idea of the mechanism behind the disease process, so that we have a better understanding. And for particularly residents and those who are to appear in postgraduate examinations, it is important from the standpoint of, instead of just memorizing certain things, if you understand that, then you can at that time yourself make out a logical approach to management of the problem. Now, in preeclampsia, because there is hypertension, it is characterized by a widespread and generalized a status of vasoconstriction. So there is vasospasm and vasoconstriction, and that there is concomitant endothelial damage also, or malfunction, that occurs after 20 weeks of gestation, and then it can occasionally, and rather I would say rarely, present as late as 4 to 6 weeks after delivery. That is extremely uncommon. I don't recall having seen a case recently which appeared so long after delivery. And clinical manifestation of that generalized vasospasm. What happens when there is vasospasm? There is increased resistance, and that uh, leads to raised blood pressure. So clinically, it is defined by raised blood pressure. And when there is raised blood pressure and that happens, then there is some renal involvement as well, which results in appearance of protein in the urine. So the disorder is that of generalized vasoconstriction. Since there is a generalized vasoconstriction, that's why there is that's why it is known as multi-system disorder. And generally, it has been seen that about 5% of pregnant women suffer from preeclampsia, and it is considered to be one of the important causes of maternal and perinatal morbidity and mortality, even in countries, because this is something which can be diagnosed early, managed, but this is generally cannot be prevented because the factors associated with development of preeclampsia are, most of them, they are beyond prevention, apart from, of course, the conditions like obesity or otherwise. But otherwise, you cannot, with the present status of our knowledge, we cannot, because we cannot change genetic makeup of a person, which is an important element in the genesis of preeclampsia. So this is not preventable, but that's why it is important to diagnose it earlier and then treat it. And that is why it is an important cause of maternal and perinatal morbidity and mortality, even in the developed countries. And the figures for the death of the babies, etc., they are given. And women in low resource countries are at a higher risk of developing preeclampsia compared with those. Why is that so? Because our preventive services are not as well developed. How many of women in our rural population have the facility of a proper antenatal care or a regular antenatal care in which we can assess them earlier on, or where some management approaches like starting low dose aspirin, etc., that can be started earlier on. Even in cities, most of the women do not necessarily have a regular antenatal checkup, and that's why in low resource countries, the incidence of preeclampsia and, of course, the consequences of that disease would be higher. Globally, the incidence, again, when you refer to one guideline or the other, another chapter in another book, it will be varying, but it is about 5 to, I would, for the sake of remembering it, 5 to 15% of all pregnancies. In the United States, it's been estimated to 2.6%, and in developing countries, it is a higher incidence. And this is hypertensive disorders are second most common obstetric cause of stillbirth and early neonatal death in these countries. The question for all of you is to tell me what is the first most common obstetrics cause of stillbirth and early neonatal death. बताएंगे कोई? जाके देखना, पूछना.
Prematurity.
Madam, hypertensive disorders are the second most common cause of this.
अस्सलाम
What
वालेकुम
is the
फ्रेंड्स,
first?
आज हमने जो है सिक्लेट 2019 का पेपर करना है और क्वेश्चन नंबर 1 है
अपने
विजाइनल
माइक
ब्लास्ट
बंद करें.
मेरे पास
इसमें विलियम है, मैकन डोरी है और बैच की टेक्निक है.
Acha. Now, preeclampsia, again, we revert back to the definition. The blood pressures, systolic, diastolic, and at least on 2 occasions, 4 hours apart, with a patient at rest. There are quite a few occasions when I refer some patients from my clinic to the labor room for monitoring of blood pressure. The objective is that does the blood pressure continue to remain high after some rest and after a little while. If it comes back to normal, then we can send her home. But if it is persistent, then, or there is a single reading, 140 by 90, 140 systolic or 90 diastolic, which is recorded 4 hours apart with the patient resting, and previously the woman was known to be normotensive or even otherwise. But if there is a reading of 160 millimeter systolic or 110 millimeter diastolic, then you don't have to have a second reading. Even that would qualify for the for the blood pressure to be assessed as raised, along with proteinuria. And the definition of the proteinuria has already been given. Now, preeclampsia with severe features. This is something which I last time also said, that there used to be mild, moderate, and severe, but now severe preeclampsia is when the blood pressure that. So 140 by 90 is the starting one, and 160 by 110 is the blood pressure limit at which the features is labeled as severe preeclampsia. And then these are severe persistent upper quadrant or epigastric pain, which is liver capsule being stretched, or new onset cerebral or visual disturbances, which again is a manifestation of vascular problem, pulmonary edema when the excessive fluid kind of accumulates, and cerebral edema also. So these are the features of symptoms and signs of on the left side that you'd see. On the right side, then if you then carry out certain investigations, you might find that the hepatic functions are impaired with ALT and AST raised up to more or less the double of at least normal, and raised serum creatinine to 1.1 or more, and reduced platelets or less than 100,000. So that would indicate severe preeclampsia. And also, in a patient who had new onset of hypertension without proteinuria, new onset of any of the following, ये नीचे दिए गए impaired hepatic function or progressive, वही वाली चीजें अगर वो हो जाए तो that means it is severe preeclampsia. And eclampsia is development of fits that cannot be attributable to other causes and may complicate severe preeclampsia, HELLP syndrome. Now, what is the mechanism? Well, we talked about this, that there is hypertension, which is the most common presenting feature, and but that is not when the problem starts. The problem starts quite early on. In preeclampsia, the hypertension shows itself after 20 weeks, whereas the mechanism by which it will ultimately be raised, that starts quite early on in the pregnancy at the time of placentation. And what various factors which are said to be associated with, they may be maternal, paternal, and fetal, which are associated with development of preeclampsia. ये बात हो गई थी पिछली दफा कि अभी तक इसके बारे में पता नहीं चला. Mechanism में more important factors relate to maternal immunological intolerance, that the mother tries to reject that fetus, which normally is not rejected, and abnormal placental implantation, and genetic, nutritional, environmental factors, cardiovascular, inflammatory. So poorly understood dysregulation of maternal tolerance to paternally derived placental, ये जो है ये इम्यूनोलॉजिकल फैक्टर्स में आ जाता है. ये ज़रा देख लेना आप ये क्या है. एंड जो then abnormal trophoblastic invasion of the maternal arterioles, incomplete. Now, degree of incomplete trophoblastic invasion of the arteries or arterioles is if there is greater problem or there is how would I say that if there is complete trophoblastic invasion, then there wouldn't be a problem. If there is less of trophoblastic invasion, then there are more chances of they're developing. And we had this diagram in which we saw here that normally the blood vessel here, the spiral arteriole, that gets dilated and it is being invaded by cytotrophoblast, and the endothelium is then changed, which results ultimately in a greater pool of blood in which the trophoblastic villi would be bathed. Here, this is the non-pregnant status, and this is the pregnant status in which the arteriole has been dilated and invaded by the cytotrophoblast, providing greater amount of blood flow. And in this one, compared to the other one, you see that the arteriole is not that dilated. And in this, we can see this is the normal in which it is dilated, and the lower one where it is not dilated. And this is the cascade of other mechanisms, starting with incomplete invasion of trophoblast of the spiral arteries and placental hypoperfusion, etc., and release of systemic vasoactive, ultimately leading to damage of dysfunction of various organs. Genetic factors, it's difficult to find, but because now many of the genetic factors which would be associated with vascular diseases, BP regulation, diabetes, and immunological functions, they may be associated with development of preeclampsia. And then why genetic factors are considered to be important in preeclampsia? Because it is seen that those women who have had preeclampsia, their daughters are more prone to develop that. It also is more common amongst sisters, and also in twins, the incidence is quite high. And since it has multi-system kind of approach, and it's difficult, so that it's unlikely that there would be only one gene that will be responsible for this. These are various risk factors, as would be said to be environmental, etc., and those which are related to. So now this is why I said that you, even in developed countries, you cannot change many of them, like nulliparity, older age, or a race, or family history. Well, chronic renal disease, if a woman becomes pregnant with that, she is more likely to suffer from this, chronic hypertension, and so on and so forth. And similarly, downwards, if you see that there are those genes, if there is homozygosity of this particular gene, then the incidence or likelihood of developing preeclampsia is much higher than if that gene is, there is heterozygosity of the gene. So, preeclampsia without severe features, that is, mild preeclampsia, generally is asymptomatic and only detected on routine prenatal examination. When you measure blood pressure, you find that it is higher, and then you would ask the patient to have urine. And those who present with features, that of course would be in more severe cases, then headache, edema, etc., those are there, and from that you can, if a pregnant woman presents with one or two or more of these features, then you should immediately assess her for presence of preeclampsia or rule it out. And all women, what are the tests which you would do? CBC, ALT and AST levels, serum creatinine, uric acid, 24-hour urine, or then dipstick, and additional tests of peripheral blood smear, serum lactate dehydrogenase level, and indirect bilirubin. The question for all of you is, what would you find in peripheral blood smear? लिखो अपने लिए, जाके ढूंढो. What is the significance of raised LDH? And what would indirect bilirubin mean? Why would that be raised? Can anybody tell me why there is peripheral, what happens or what changes one can see in yes, that's right. Dr. Yasmin, Malka Yasmin has raised a hand. Yes, that's right. Good, good. And LDH, what about LDH? Raised LDH? चलें, जाके देखना तुम लोग. And in peripheral smears, then there is also deformed red cells in addition to what you have said due to hemolysis. Now, these are the tests which need, or what happens with these renal values: proteinuria, urine dipstick, protein creatinine, serum uric creatinine, and the asked of the target cell hemolysis, right? Okay. And then platelet coagulopathy related platelet count, elevated PT or APTT, decreased fibrinogen, and increased D dimer levels. What is the mechanism? Why D dimers are eclampsia? Again, something that again is important to understand the whole process, what happens. And hemolysis related, as many of them have made a comment about this, that abnormal peripheral smear is because of that hemolysis related issues, indirect bilirubin raised and LDH level. वो भी दिया हुआ कि क्या इस तरह से होगा. Good, good, that's nice. Now, fetal assessment. This is a little a brief description of fetal assessment. I would also add to this the clinical assessment of the fetus. You may find that the height of the fetus is less than what one would be expecting, and the assessment, clinical assessment or palpatory assessment of the fetal size is that of a smaller fetus. One might also decipher that the amount of fluid is less. So those are the things that one would see on clinical assessment of the abdominal examination. These days, ultrasound is so widely and so readily available, and one just has to put the probe on the abdomen, and in just a few of seconds, you know much more than a palpation would tell you. But at the same time, it is important that uh, the obstetricians, they need to develop these skills of assessment of the palpatory assessment of the fetus, the lie, presentation, back on which side, right or left of the mother, and also some assessment of about the amount of fluid around the baby. So those, that's important, and some guess about the it's at best it's a guess. I'm quite wrong many times about the weight of the baby, as I said, but that assessment is influenced by many factors, by, for example, the stature and the body contour of the woman. In obese and overweight women, it is more difficult to ascertain the size of the fetus, or the lie, or even the amount of fluid. So that's one of the factors. And similarly, in nulliparous women, the abdominal wall is quite taut, and therefore assessment may not be as easy as in a multigravida. Now, ultrasound overcomes all these drawbacks and gives you a better status of the fetus by biophysical profile, evaluation of growth restriction, which will be on serial ultrasounds when you see that there are certain parameters, serial or even one, in which that you see that there is head sparing effect, and that would show that there is growth restriction, and also on Doppler of umbilical vessels and other vessels, but more of umbilical vessels so far as placental insufficiency is to be assessed for this. So this is ultrasound, and then of the cardiotocography. How is the fetal heart responding to the nutritional environment that is available to that? And that depends, of course, on the status of the vasospasm around. So fetal assessment is clinical, ultrasound, cardiotocography, and that you do it first, and then that establishes the baseline, and then depending upon the severity of the disease, then you can have it done more frequently or at intervals to see how the patient is faring. The ultimate cure for preeclampsia or eclampsia is the delivery emptying of the uterus, because it is the placenta or associated pathology which is the cause of that. And if you deliver, then that will be taken away, and the things will revert back to normal. Management without severe features, if that's in case of hospitalization, initial assessment carried out at that time, and if you find that the things are well within control, then the patient can be sent home. And initially, if you find that there are indications like that there is worsening of preeclampsia, or there is a sudden rise in blood pressure and the blood pressure is getting worsened, or there are complications of preeclampsia, then you continue to have the patient hospitalized. Expectant management of fetal and steroids for lung maturity, and induction of labor after 37 completed weeks, so the baby has attained sufficient maturity, and by that time the fetus is generally not adversely affected. But in cases of severe features, the delivery may have to be carried out earlier, sometimes even before 34 weeks, but usually one should attempt as far as possible to take it beyond 34 weeks. Control of blood pressure and fits, if that happens, that those are priorities in severity of disease weight against the prematurity. Now, acute treatment of severe hypertension in pregnancy, hypertensive treatment, these are the levels. And goal of hypertension treatment, maintain blood pressure about 140 to 90. Nice guidelines, the level given is 135 by 85. So that keeps changing, but 140 to 90 or 135 by 85, that is okay. And the different medications that are used, hydralazine, labetalol, nifedipine, and also one would add aldomet, methyl dopa. But in severe cases, not severe cases, in severe cases, these are the drugs, which is because we are talking about severe cases, so hydralazine, labetalol, and they can be given intravenously. And prophylactic treatment with magnesium sulfate is indicated for all patients with the severe features of preeclampsia. So that also needs to be added here. Diuretics. Many patients would present with edema and generalized edema, but one should resist the temptation of administering diuretics, because diuretics are going to further complicate the situation by disturbing electrolyte balance of the patient. And these patients, they are, and already because of vasoconstriction, the intravascular compartment is comparatively restricted. And therefore, by diuretics, one would be aggravating that condition of comparative ischemia. Because what you see on in case of edema is that extravascular space has excessive fluid, but intravascular is comparatively restricted. So fluid management has to be titrated according to that. And on one side you don't give diuretics, and on other side you also do not overload. So patient should be fluid restricted when possible, at least until the period of postpartum diuresis. CVP total fluid should generally be limited to 80 milliliters per hour. Treatment of convulsions, that is magnesium sulfate. You all know, I'm sure, loading dose of 4 gram by infusion, by slow intravenous injection, and then and it could be given intramuscularly as well, and then infusion of 1 gram per hour maintained for 24 hours after the last fit. Recurrent seizures, then additional bolus of 2 grams or raise the hourly dose from 1 to 1.5 or 2 grams per hour. And it is indicated in all patients with severe. Other drugs, lorazepam and phenytoin. these days we take magnesium sulfate for granted, and it has been on WHO list of essential medicines for quite some time, and it is freely available. But maybe 20-25 years ago, magnesium sulfate was not so readily available, and we used to, when I was a resident, we used to give not phenytoin, or lorazepam was comparatively newer at that time. At that time, there was something which was known as lytic cocktail. जरा देखना हिस्टोरिकल इम्पोर्टेंस के लिए कि व्हाट वाज लिटिक LYTIC लिटिक कॉकटेल क्या होती थी. Criteria for delivery: preeclampsia with severe features, uncontrolled blood pressure, ruptured membranes, oligohydramnios, oliguria, serum creatine which is high, or or less than 5 percentile estimated fetal weight, severe IUGR, and a non-reassuring biophysical profile, or a reverse diastolic flow. You all are very much familiar with all these features. And what we are not actually very familiar with, because these days we don't see many cases of eclampsia. I personally think, I don't know, am out of government hospital for quite some time. I'm sure over there the cases of eclampsia still come, but the incidence would be much less. Like we see very few cases of now vesicovaginal fistula compared to what they used to be 30-35 years ago. Similarly, now eclampsia is comparatively less often seen. How many of you have seen a case of eclampsia here? यहाँ पे एक हुआ, हाँ एक, मतलब वो साल 2 साल बाद कोई इस तरह से हो जाना, कोई अचानक इस तरह से हो. और similarly, we don't really see many cases of pulmonary edema, shortness of breath, some these cases of severe nature, because they are there is intervention before that. And why 4? It's a big dose. Why 4 grams? It's a big. Consultant once asked, I couldn't. Well, the dose of 4-gram magnesium sulfate has been there since, at least I know, since 1974. That is the first edition that of Williams Obstetrics that I read it in. And magnesium sulfate was introduced by Parkland Memorial Hospital in Houston, Texas. And the doctor who started this was, I forget his first name, was Pritchard was the name. And he started, and those days in 70s, the first paper came in when he said 50 cases or consecutive cases of eclampsia without a single maternal death. And that was when it was said that they used magnesium sulfate in that hospital. And this is the same hospital where President John F. Kennedy was taken after he was shot in the neck, Parkland Memorial Hospital. And then they published another series in which there were 75 consecutive cases. And then third paper was 100 consecutive cases of eclampsia without a single maternal death. And that is where magnesium sulfate started from. And at that time, they used to give it, as I said, intramuscularly. They used to give it intramuscularly in the buttock, 4 grams. And the second dose also was given 4 grams after a couple of hours in the other buttock, and then they started. So those were the initial days of use of magnesium sulfate, when they gave it intramuscularly, and later on it started intravenously. Oligohydramnios. So 4 grams is the standard dosage, which was started right in the beginning, and that is there since 1970s. And that is something which is required at that time, that bolus dose and then the maintenance dose. I do not really know why is that considered to be a big dose. ये तो उसी तरह से है जिस तरह से वो पेशेंट कहे कि जी ये मुझे ना स्ट्रॉन्ग वाला एंटीबायोटिक ना दें. And what does it mean? What is strong antibiotic? It's the dose of, let's say, ये जो क्या है, ऑगमेंटिन क्या होती है, कैलकुलेटेड एमोक्सिसिलिन, उसकी डोज है 650 या 1 ग्राम. तो वो ये तो 1 ग्राम तो बहुत ज़्यादा है. How are we going to, now that has been assessed and tried repeatedly, and I have given you a reference of Dr. Pritchard's. You can go and find the references for that. I've told you where it all started from. So that is it. Oligohydramnios with preeclampsia is indication of delivery, or we will go as Doppler studies in this case. Please explain. Right. So you see, that's a good question. Nice question. Uh, the answer to that is there are three parameters actually that you look at when you decide about delivery. One is the amount of Liker. The second is the Doppler of umbilical vessels. And third is the CTG, cardiotopography. Now, these are three, and we have to give importance to these three. I would give importance to number one. The top for me would be the Doppler study of umbilical vessels. If there is uh, a reversal of flow in the diastolic phase, that is an indication irrespective of the other. Then there is no point in doing a cardiotopography or assessing the amount of fluid around the baby. And if the amount of fluid is less, then Doppler is okay and CTG is okay, then you can continue. An important aspect is, I just wanted to make this is my, I must have read somewhere, but my observation is, and you can try on your own as well, is that in those patients who have lesser amount of fluid around the baby, which is oligohydramnios, if you ask them to lie on their side for most of the time during the day, I ask my patients to lie on their side 20 hours out of 24. It is not lying when they lie in the bed that they should lie on side. It is 20 hours out of 24, and in the rest 24 hours they should walk about to improve their circulation. Now, the rationale behind that is that when the patient is lying on her side, the pressure of the pregnant uterus is taken off the inferior vena cava, and that actually results in that is something that I've read, that raises the blood flow through the placental bed by 30%, by a factor of 30%. And I have seen quite a number of patients who have done well even starting from 22 weeks. I remember one who had oligohydramnios at 22 weeks, and she went on to term to deliver the baby. Only yesterday, I had a patient who came with an amniotic fluid index of 13, and 2 weeks ago, the amniotic fluid index was 10. It was by the same ultrasonologist. So that had made some difference. And when there is increase in the amount of fluid because of, you see, improved circulation in the placental bed, that also means that the flow towards the baby, that also improves. So that's it. And but if there is persistent oligohydramnios, which is not because of some renal pathology of the fetus, and that is also associated with raised blood pressure and with compromised umbilical vessels flow, then the baby should be delivered. Or we'll go as Doppler. But if the Doppler study is reassuring, then you can continue. And till the time that you feel that no oligohydramnios, because it'll be a rather uncommon thing that the Doppler is all right and there is no fluid, or there is severe oligohydramnios. So you go along with this, but number one would be Doppler. So Doppler, CTG, and the amount of fluid. That will be my order of assessment of these. चलें जी, thrombocytopenia हो गया, placental abruption, unexplained coagulopathy. So this is about timing of delivery. If it is not severe preeclampsia, then you try to take the pregnancy beyond 37 weeks and then you induce. And the mode of delivery will, of course, be dictated by factors other than this. There is no cephalopelvic disproportion, previous number of cesarean sections, presentation, etc. And how does the fetus take the stress of labor? So that will be seen by like that. So, but the timing for delivery in not severe cases beyond 37 weeks, and those in which there is severity, if the situation would allow you to take the pregnancy beyond 34 weeks, that should be tried. And otherwise, whenever, of course, you may have to deliver even at 30 weeks, it is, if it is very severe. So those are the things that now are a matter of routine: when to deliver, when to induce or do a cesarean section, and what precautions to take before that, like dexamethasone, etc. So that is it. And postpartum, it's important to remember that many patients may have a reduced urine output for a few hours after delivery, so one should not panic at that time and start giving furosemide. So desist from that and wait for that. Wait for normal urine output. And magnesium sulfate should be continued at least for 24 hours after the last fit. And liver function tests and platelet counts should be documented to have come down or showing a decreasing trend before the discharge from the hospital. And elevated may be controlled with nifedipine or levitalol, which now we all are quite aware of that. ये थोड़ी बहुत चीज़ें हैं कि इनको भी उस लिहाज से देखा जाए, पेशेंट को जाते हुए किस तरह से हमने बताना है और क्या उसकी काउंसलिंग करनी है वगैरह वगैरह. So that's it. Now we have some time. If there are any questions, you are welcome. Only thrombocytopenia is indication for worsening thrombocytopenia for delivery. Thrombocytopenia, actually, Malik Tawkir, is one of the features of worsening preeclampsia. And in itself, in isolation, I don't really think that would be an indication for delivery, but it will be part of the whole thing, like severity of protein urea, like other features. So they have to be taken along with others. Why 4 grams, a big dose? Right? Any questions? Ahmed? Thank you very much.
Thank you, sir.
चलिए.